Okay.
Are you with me? Now you see the screen?
Yes, we see the screen.
Thank you very much. It's a big pleasure for me to be part of this FNS Neuroanatomy Committee webinar. It's, I think, a beautiful webinar with a lot of different aspects. And I will cover endoscopic spinal surgery. I have to disclose that I have a consultant contract with Stort. And I have received honorarium from some other spine companies. This is where I'm from. This is Europe. You see, it's very close to the French border. So 1 hour from Frankfurt, Strasbourg, and Luxembourg. And this is the department where I work at. And this is the university campus. So we switch now to a very different topic. We have a lot of different presentations on spine surgery, but now we switch to spine endoscopy, which has some peculiar aspects, I think, which are related to the technique I want to discuss. So what is the big advantage you have with the endoscope? A very good visual quality, although the resolution is much less than with the microscope, since you have the endoscope and the camera right very close to the target area, you have a very, very detailed image. You can look around the corner, and if you have a smaller approach, because you can use reduce the collateral damage in many indications. Ideally, this technique results in a new surgical technique. Well, I think this is ETV in neurosurgery. This is a really big advantage when you can do this endoscopically, but it's rare. For spine, I think transforaminal, this can only be done with a real endoscopic technique. So there is ideal advantages because you have new surgical techniques using the endoscope. In my talk, I will focus on degenerative indications. I think there's another very good indication in thoracic fractures, thoracoscopic approaches, but this is not the topic of this presentation. And in contrast to other endoscopic indications, we have no preformed cavity. So we have to prepare our space to maneuver the instruments and the endoscope. Also, we have very good results with microsurgery, and we need sufficient decompression of neurostructures. So this is, well, a major aspect, which makes it very difficult to see advantages using the endoscope in spine surgery. What can we expect? Well, smaller reduction of muscular trauma, maybe a mini opening, very focused opening with high magnification. Maybe this might result in a decrease of scarring at the spine, at the dura. And then there's a significant patient demand, and we have, well, we want to have less postoperative pain and faster recovery. There's a vivid, very controversial discussion, particularly between microscopic versus endoscopic. And then if you think about endoscopic, then you discuss tube-based versus full endoscopic techniques. And then there's another discussion, transforaminal versus interlaminar. And I presented this at the World Spinal Column Society virtual world meeting in late August, so 1 month ago, about transforaminal, and I will not go till today. I will just present to you the endoscopic options. What is the status of evidence in 2020? We have shown that there is no longer a higher recurrence rate and a higher complication rate when we use the endoscope than with the microsurgery. So it's not that we have evidence that it's better, the endoscope, it's just that we have the same recurrence rate and the same complication rate we can reach with the endoscope compared with the microscope. However, immediate postoperative pain, particularly if you use the very small tube-based procedures or the shear endoscopic procedures, is reduced, and you have a faster recovery. Of course, you have then, with a very small skin incision, a superior cosmetic results. However, there's no evidence for superior long-term results in the year 2020. So what is the ideas and the approaches? What is possible? You see here all different endoscopic techniques. As I said, tube-based endoscopic assistance and then percutaneous shear full endoscopic. I will not go too much into detail here, but rather, and for me, it's important that we can divide the techniques in an interlaminar approach and a transforaminal approach. So a far lateral, posterolateral approach in the extraforaminal space and the interforaminal space, and then an interlaminar approach where we can basically deal with the whole spinal canal. These are the different indications: a standard medial lateral disc prolapse, a significant lumbar canal stenosis, or as you see here, an extraforaminal. When we look at the status of evidence, we have to evaluate only the most recent papers, let's say the last maybe studies within the last 8 to 10 years, because there's a dramatic improvement in technology in surgical techniques in the recent years. You see here, for example, a definition system. You see that the information you gain just from the image is much, much better with the HD camera system. And now we have 4K, which is even better. So I want to discuss the tube-based system, the transmuscular approach. So this surgical technique is very, very similar to the open microsurgical technique. The only difference is that we don't go at the spinous process down. No, we go a transmuscular approach right to the target area. So we directly approach the target. So we reduce the muscle trauma. We do not detach the muscles. We don't retract the muscles as much. And we just focus on the decompression of the neurostructures. What is important? The difference between the tube-based system and the open microsurgical technique is, the main difference is that you really have to plan the procedure from the beginning. You need an X-ray for perfect localization of the skin incision, and then you dissect the fascia with the skin incision, and you use the dilators to introduce the endoscope. Parts of the procedures can also be done with a microscope with a tube-based system, but it depends on the diameter of the tube, whether you have to use the microscope, or you can have to use the endoscope, or you can still use the microscope. Here's an example. This is for one of our systems, the EasyGo system, that you can use almost all diameter for manipulation when you have introduced the endoscope. And you can think that because you don't need the corridor for the microscope, you can reduce the diameter of the end of the work tube significantly when you use the endoscope. Typical example here, you see a sequester disc prolapse, a 4-5 caudally migrated, and this is a typical situation, what it looks like. I will forward a little bit. You see in the upper part of the screen is the midline, and the lower part of the screen is lateral. And just to get the idea what the magnification is like, this is a 2 millimeter Carrison punch, and the suction device is 2.3 millimeters in diameter. So you expose here the thecal sac, the dura. Then we retract, basically like a microsurgical procedure. The only difference is that it's really small. I mean, if you use a 4 millimeter Carrison punch, you would not be able to bring it in. You see here now the disc prolapse. Then you just manipulate and mobilize, and ideally, of course, a huge sequester is coming out. This can be done with a skin incision like 1 centimeter. So the cosmetic result is very good. In contrast to this interlaminar approach, what we use for intraforaminal and extraforaminal disc prolapses, a posterolateral approach. You see here the technique we use. It's an example here with a spine tip technique, but there are many different other brands available, products available, which I think do all the same job and will provide the same results. So here, this is the system, 8 centimeters in length. You see a 15-degree optical lens, and you see here irrigation and suction channel, an optical lens channel, and then a working channel with about 3 millimeter diameter. The difference is that this procedure is completely done under water, so continuous irrigation. What is the technique like? So we use the inside-out technique. We enter the disc space with a needle, come from lateral, calculate the distance, and so usually it's 12 centimeters lateral. Then we approach the disc space right at the frame, and we do discography that we are inside, and then we change to the working channel and introduce the working channel, and then we retract that we are right at the intraforaminal space. You see, this is of course an ideal example. You just go in, basically everything has been mobilized because you went through the sequester, and then this can be done in 10 minutes or less. Skin incision here is even smaller, like 6 to 7 millimeters. Very good cosmetic results. And these patients, indeed, they have very, very, very minimum postoperative pain. So now I come to the status of evidence. What is evidence? What we can look from the randomized studies, what we can gain from the randomized studies, is the endoscopy superior to microscopy? And you see that the problem is that there has been various endoscopic techniques included, various indications, and various outcome criteria. So when we go through all the data right now, the application is possible in a wide range of indications in degenerative spine disease. Most of the randomized studies are lumbar. We also have very good results in cervical applications, but there are very few randomized studies for the cervical. And in all these recent randomized studies, we have evidence that the complication rate is no longer higher than with microsurgery. We have evidence that the reduced muscle trauma by use of sheath systems or pure endoscopic systems gives better result. We have less muscle pain, less muscle scarring, and we have, because of the small skin incision, superior cosmetic results. These two things that we have evidence for from the randomized studies. When we look at the level of evidence for long-term results, for revision rate and success rate, then we have to be honest that although there are some randomized studies available, we have very, very low evidence, very weak evidence that we have better results with the endoscopic system. So on the long-term revision rate, success rate, we have to be honest that microsurgery and endoscopy provide the same results. I have a couple of different indications now. When we look at lumbar canal stenosis, for example, we would come as an example from an interlaminar approach and use this with a tube-based system. So this is the contralateral side. We do the decompression with a diamond burr and a sheet-based endoscopic system. So this would be in our hands. This is one of the most frequent indications we have now. This would be a classic indication for an endoscopic tube-based interlaminar approach. So this looks like this in the post-op CAT scan. Classic indication for an transfemoral shear endoscopic approaches. This case example here, you see it's an L4, L5 left-sided intrafemoral disc prolapse. And then you calculate the approach like this. This is usually, in this case, was 12 centimeters lateral. Use the posterolateral approach. We go into the disc space and then we retract. This is the technique. Puncture of the disc space, discography, and then Zeldinger technique, guidance of the endoscopic system. And then you go in and retract and mobilize. And this is a typical case when we have a huge sequester like this. This was done in 6 minutes, 49 seconds. However, we only use this technique in soft disc prolapses, intraforaminal or extraforaminal, everything which is in the spinal canal, and particularly we have a lot of old patients aging population, and you have to drill a lot and you have to mobilize the tissue, then I think it's better to use an interlaminar approach. So to conclude, we have the same outcome right now when we use the endoscope as we have with the microscopic techniques. We have standard interlaminar techniques, which at least we prefer to use a tube-based system. But we have a new technique, a transfemoral technique, particularly for interfemoral and extrafemoral soft disc prolapses, which gives very nice results. At both endoscopic techniques, we have less muscular damage and superior cosmetic results in comparison with the microscope. So I think particularly for the right indication, endoscopy will play a significant role in the treatment of degenerative spine disease in the future. I thank you for your attention and my whole team for collecting these data. Thank you very much.
Thank you very much, Joachim. It's a wonderful presentation. I'm sure cost effectiveness will become a very important component of this procedure, with the decrease of the length of stay. I can imagine these cases you might send them same day procedure or outpatient procedure. I have one question. What is the percentage of cases you revert to microsurgery from endoscopy in your practice?
Yeah, good question. It's actually very low, surprisingly low. In the beginning, in the learning curve with the tube-based system, the learning curve, we have published this recently, I think, in World Neurosurgery, is about, well, depending on, of course, on your personal experience, between 15 to 30 cases, so very few. So in these first, let's say 20, 30 cases, you have some revisions, some converting to microsurgery. Later on, it's very rare. I cannot remember when the last time when I switched from endo to micro. This is different for the transfemoral system. For the transfemoral system, the learning curve is not that steep. It takes a long time to have a good result. So I think you have to do minimum 60, better 100 cases. And still, we sometimes switch from endo to micro, particularly if we have the impression that we did not take out and decompress the nerve roots in a sufficient way. Then we actually do not hesitate to switch to an open procedure. But I have no clear data how often that is. Let's say 85%, not more than that, but not very rare.
And since we have young trainees attending this webinar, do you advise them, whoever wants to proceed doing endoscopy, to build up the learning curve in microsurgery?
I think it's better. I think it's better that either you have to do anatomy lab or you have to do microsurgery, because the anatomy is not very obvious when you have these mini openings. This is the difficult thing in learning the endoscopic techniques. You have to exactly know where you are, otherwise it's a disaster. So I think either you do a lot of anatomy practice, or I think you need to do some microsurgical open cases before.
Thank you. From the panels, any questions?
I just want to comment on something. Hi, Joachim. Good to see you.
Hi.
Do you think at some point you'll be doing intradural procedures with this endoscopic technique?
Well, some do in intradural procedures with this technique. I don't know. So rather, when I do like cavernoma, epineumonoma, so really intermedullary tumors, I want to have all the skills available. So I tend to do a rather large opening. I don't want to have a small opening. I rather do, if you do laminotomy, I rather add a segment which I might not need than being too small in the approach. So I personally, I don't think that this is the focus for an endoscopic minimally invasive procedure, but some do, and some present nice data. So I think it's possible. But if you want to have the best results, to be sure that you can have all the bimanual skills, to get the best result for the patient, I'm not sure whether we really should proceed with this. Maybe some selected cases, very small lesion, like a neurinoma or something, you know that you just open up the dura and it pops up, then of course it's no problem.
Great. If no further questions, thank you, Joachim. We'll move to
It's been a pleasure.
It's a pleasure to have you.